Thank you very much for having me. I feel very honored. I'm here to talk to you about plasmapheresis. My background is dialysis and plasmapheresis. Started off back in 1990 in Europe. Plasmapheresis has been around for a long time. And even though it has been around in the past, it hasn't really been fully explored as part of the treatment of various conditions. Most of the time, doctors turn to medication. But plasmapheresis has been around for a while, back in the 60s. In my background, I find that it's a type of treatment that helps most of my patients, especially the treatment. Apart from the plasmapheresis, patients receive other medicine, IV medications as well. But I feel in my experience, plasmapheresis have a lot to contribute to the recovery of most of my patients. Okay. Now this evening, I want to go over general overview of plasmapheresis, what it is all about, how it's done. I want to go over the benefits of plasmapheresis and how does a patient prepare once you've been told you need the treatment. How do you prepare for the treatment? And then last but not the least, look at the outlook afterwards, after your treatment, how you feel. Okay, so there's a lot of information. Please stop me if you need to ask a question. I've been struggling because there's so much out there and I didn't know how much to give you so that you don't leave here confused. We are hoping I'll keep everything to the minimum and the simplest way so it will make you understand. Sometimes I forget myself and I think I'm talking to professionals and then I'm using all these medical jargons. Just stop me if you don't understand something, okay? Okay, so having said that, what is plasmapheresis? Okay. First of all, a lot of people hear the name plasmapheresis or they see it or they see me doing it. Some people, the first thing they ask me, is this dialysis? I get that a lot. And I have to stop and explain no. It looks like dialysis because it's dealing with blood. And of course, you see dialysis machine, it's all tubes and blood in the tubes. And this one too, you see it's all tubes and there's blood in the tubes. So many people confuse themselves with dialysis. But in actual fact, the difference between dialysis and plasmapheresis, or we call it plasma exchange, is dialysis is cleaning the blood. We are taking out toxins from your blood. But plasmapheresis is we are actually separating your blood and removing part of it. Now, blood has got some components. You have your red blood cells, you have your plasma, you have your platelets, and other components as well. Now, for many diseases for which we use plasmapheresis for the condition or the illness is actually in the plasma. Whatever is causing that condition is actually found in the plasma. So what we're doing with plasmapheresis is we will separate the blood. We do not touch the red blood cells. We don't touch it. But we remove all the plasma, not all of it. It depends on how the others comes through. But research has found that each plasmapheresis exchange or procedure actually removes about 60% of the antibodies causing the problem. Okay, so it's very, very effective. So How does it work? Stop me if you have a question, please. So that's the general information about the plasmapheresis. We are separating your blood, and we are removing the plasma part, and we are returning the red blood cells back to you. Now, when we remove it, we have to replace it. If we don't, then we have imbalance of your blood volume. So if you think about it, we have a cup of water, and some components in the water we have to remove. What do you think is going to happen? It's going to be shortfall, right? If it was full, it's going to be like halfway, right? In your body, that is going to affect you because we are removing quite a large volume of plasma, which is also fluid, part of your body fluid. And if we don't find a way to replace it, you will drop your blood pressure, and it will make you feel very, very sick. And so one thing, anytime you hear plasmapheresis, two things must come to your mind. They are going to remove my plasma, and what are they going to replace it with? Okay? So that you don't become what we call volume depleted. If the volume in your blood is depleted, it's going to affect you. So always we have to weigh. And yes, there's been times there are 3 solutions that we will use to replace your plasma as we pull out, so that you don't drop your blood pressure and equilibrium is maintained throughout the process. So we have a normal saline, which is just salt water, sterile salt water, that you can use to replace. And basically what you're doing is increasing the volume as you give the normal saline, and at the same time pulling the plasma from your blood, so that you don't become volume depleted. Now the normal saline has, even though it's giving you volume, it doesn't have the ability to expand your fluids, and therefore it will work to a certain extent. It will not completely replace all the plasma, because the plasma is some kind of a protein, so it will not be completely replacing that. We can use another solution that we can use is albumin, and that is what people call liquid protein. They are known to expand volume, so they're very good. They look similar to your plasma, so we find that is a lot safer to give during plasmapheresis to replace the plasma that we're pulling from you. The other solution is, of course, donated plasma. People who donate plasma to the blood bank, and we will use it. Having said that, the different conditions warrant different solutions. Let me give you some example, and I have a whole list of conditions that plasmapheresis is used for. It's not just myasthenia gravis. Okay, let me first of all show you. That's the machine. This is an older version of the machine that we use. I come from Europe, and in Europe we don't use this. We use what looks like dialysis filter. So you can use a filter, or you can use this. This is called a pheresis machine. And what this does, it separates the blood, the red blood cell, from the plasma. The other one that I talk about with the filter works differently, but they both arrive at the same results. Okay, but I like this better, and I prefer. I've used both, but this is by far the best to use it where plasmapheresis is concerned. This is the best machine. We have. It's too loud. I've got a thick voice. Okay, so this machine, inside the machine, is called a centrifuge. That is where all that happens. When we start the procedure, your machine is drawn from you. Your blood is drawn from you. And it goes into the machine, and I can show you inside the machine what it looks like. Okay, this is the tubing that your blood goes through. And in this tubing, your blood is separated. It all happens inside the machine. And it spins, you know, that channel, that round thing, spins over 1,000 times a minute. And by doing that, it separates the red from the plasma. Now, all of them comes up. Let me see if okay, this is when it's loaded. So the first one I showed you this is after I have done and I'm pulling it out, but it's loaded into the channel. Okay. So once it's done, you see those 3 lines? You see those 3 lines, the pink and the yellow? Okay, this is where the separation happens. So in the yellow, you have your plasma coming through there. And the pink one, you have your red blood cells coming through there. And it's all channeled through the tubes and back on top of this machine on the outside. And the red blood cell is returned to you, and the plasma is channeled through the bags hanging up there. And that is your waste bag. Okay. Like I said, through this process, at the end of each procedure, we hope to have removed 60% of the antibodies in your blood. Okay. So basically, if you hear about plasmapheresis, it's talking about a process where the liquid or the plasma in your blood is separated and is removed. The plasma is removed. It's just quite simple as that. Okay. So now, how is it done? Like, that's what I've told you about how we do it. Connect you. We must gain access to your blood. And I'm sure some of you who have had the process, you will know that you will have to be either taken to the radiology department or intervention radiologist coming to your bedside in the hospital. You can actually have it done as an outpatient, and they would insert a catheter, what we call a catheter. And the reason why we insert a catheter, and usually we choose the biggest vessel in your body. And that biggest vessel is found in your jugular, right here. Okay? It's big enough to have a tube pass through it. It's also elasticated, so you can expand a little bit. Now, that jugular vein runs through from your neck all the way down, and it joins at the entrance of your heart. And so there is a junction very close to your heart. That's where the tip of that catheter sits. So it's very long, and it's very big in diameter. And the whole idea is to pull large volumes of blood from you. Okay? So that is the vascular catheter that is placed so that it will enable us to pull your blood, pass it through the machine, and take out those plasma. So we've gone about how it's done and how it works. We know that it removes those antibodies. Now, we know that this treatment helps a whole bunch of conditions, and it's not just myasthenia gravis. We have about 4 different types of conditions that have been grouped in different groupings. So we have the neurological conditions of which myasthenia gravis form part of. Then we have hematological condition, where people have issues, problems with their blood, that this treatment can be used. A condition such as a TTP, we normally call, it's got a long name, thrombotic thrombocytopenic purpura. And what it does is a hematological condition. What it does is your body makes antibodies and it fights against your own blood cells. And it starts breaking them down and clotting. Okay? And when that happens, you start bleeding. And you can bleed anywhere or any part of your body. And that can really make you feel pretty rough. We use the plasmapheresis to help, as well as other medications. But with the TTP, the first line of treatment is plasmapheresis, and it does really help. And then we have transplantation. People having transplant and rejecting, plasmapheresis is used to help and stop the rejection, because we can remove those antibodies causing the rejection. So that's pretty cool. And then we have, so I've said 3, the neurological, and then we have other conditions such as cancer, myeloma, and also people with high cholesterol. We can use it, to remove it. Then we have patients with sickle cell. We use plasmapheresis also to exchange their whole blood and give them good blood. So there's a whole bunch of them. And if anybody is interested to see a list of conditions, I have a whole bunch of lists on my slide. I didn't think it was necessary to put it. We have first line of treatment that really this treatment benefit is a whole over 100 of these conditions that we use plasmapheresis for. So I won't bore you with that. There's too much. I know Myasthenia Gravis is one of them. Okay, so if your doctor should recommend plasma exchange, it's also called therapeutic plasma exchange, which is TPE. Know that it's really legitimate decision that your doctor is making. Okay? All right. So let's talk about the benefits. I have already mentioned that it removes so much of the autoimmune disorder or the antibodies. So when you have somebody with myasthenia gravis, as you all know a lot about the muscle weakness and all the symptoms that you develop, plasma exchange can help improve your condition a great deal. It can. And in terms of the number of treatments that one needs, all depends on the patient and how your body responds to the treatment. But there is generally a treatment schedule that the doctors or that is recommended by the professionals. The first set of 5 treatments is highly recommended that the doctors would usually order 5. And you see that somebody will say, I was giving daily. And somebody will say, I was giving every other day. There is a reason for that. So if you have a neurological disorder, it's really very important that we do this every other day, because it gives your body time to recover after one procedure. So if we give it another 24 hours, what we really are looking for is how much is your body producing of those antibodies. And it helps the doctors to manage your care very, very well. Because you are always making those antibodies. You're making them. But when you, up until the time that we first start the treatment, we will do all sorts of lab work. And, it is a protocol to do these lab work because it gives you a baseline measurement of those lactate dehydrogenase, which is the LDH or the antibodies that we measure. And everybody have a bit of LDH in them because, you're eating, your body is functioning, it's part of the waste, the product that your body produces. But if you get a condition where your body is not able to deal with it, and then it's piling up, so you're getting lots and lots and lots of these antibodies in you, then we have to treat it, because then it becomes a disease or a disorder. And so we have to monitor how much of these antibodies are in you. If the first baseline we do, if it's antibodies, is like 2,000, and I've seen people produce more. And usually the first treatment can, is good to even half those antibodies, or even a third, to remove a third of it from your blood. So that first treatment is very, very important. And then after that, with each treatment, prior to each treatment, we need to know how much antibodies you're producing. And it helps the doctors to make that decision, whether to continue or whether to slow down. And, for us who do the treatment, we follow a protocol. So if your antibodies continues to rise, the doctor is not with you 24/7. We are the people that, advise the doctors, hey, antibodies continues to rise. Do you want to continue with the treatment? We've had 5. Do you want another 5? And we tend to discuss with the doctors. And quite often they'll say, let's do another set of 5. But usually the first 5 treatments usually are enough. And if it doesn't work, we do another set of 5. Usually after the treatment is done, and even if your treatment is stopped, one thing that you should be mindful is this plasma exchange continues to work. It doesn't stop. So even though we are not physically doing the treatment, you have had those treatments, and it will continue to work for a while. And so don't think, oh, it's been stopped, my disease is going to come back, or my disease, first of all, we're not curing it. We're just managing the symptoms. That's one thing that we have to understand. We are just managing the symptoms. And if the symptoms get worse, by all means, contact the doctor, and he can order some more treatment for you. Let me pause here. Any question? Then we continue. Okay, thank you. Let me add a little bit more to that. Those pots are put in a very, very much controlled manner. First of all, you will be sedated while they're doing that. Secondly, they will be stitched into your skin. So bleeding is very minimal. Now, my dear friend here was talking about the temporary one and the permanent one. When you first come to the hospital, they will put a temporary one in. And that one we tend to, when we want it done quickly or fast, we want to gain access to your blood very fast. They don't have to do a lengthy procedure, so they can do a quick one. It still goes through your jugular, but it's a quick one that is temporary. We can use that, and it's still stitched in. They still put a stitch there that stitches to your skin, so there's no room for it to fall or start bleeding and you bleeding to death. Or it doesn't happen that way. Now, when it comes to the doctors realizing, okay, we're gonna need this treatment longer than we thought, let's put in a more permanent access. And that permanent access that he's talking about can last up to 12 months. Some people have had it even longer than that. And that is tunneled through the jugular vein, is tunneled under your skin, and is stitched. Now, halfway through the tunnel, there is a big cuff that stays under your skin, and your skin kind of grows around it. And so it's very tight, and I would be so surprised if a tunnel catheter falls off. It never does. And it's very safe. So in terms of, have we answered your question? In terms of it getting pulled out or bleeding out, it doesn't happen.
Okay, thank you. Is one shot, is that the entry and the exit point? I mean, like one texture and then?
Okay, I had a clip that I was going to show you. Unfortunately, the internet doesn't work. It's like a Y shape. Okay, so you have the bottom part, which is the longest part, goes inside the body. And that's the tip I was talking about that sit at the junction closer to the entrance of your heart. Now, the other Y tubes comes out to your skin. And in the Y tubes is color coded. We have two clamps, one on each tube, a blue and a red. And there is a reason for that. Now, the red one, the plasmapheresis tubing that is going to be plugged into your catheter, has got a red and a blue. Now, the red being, we call it access. That's where we're going to pull. And the blue that's when we're going to return back to you. So as it's pulling, it's returning. It doesn't collect all in one bag and then give to you. We're doing this process at the same time. Taking and
Body, like at the aorta that goes back in?
no. You know the Y-shaped thing? Okay. The tube is just one tube. It's just one tube in the jugular vein. It sits there and it's stitched into it. But inside of you, the tip of that catheter is sitting in that tube, in your vein. Okay. So you know your blood is always flowing. Yeah. So when we hook you onto the blue and the red, it's pulling inside. I wish I had brought a catheter with me. Inside the catheter, if you cut the catheter into half, you will see that there is a segment dividing inside. So you're not pulling the blood that is coming from the red side. Each one will have their own path. Okay, so you are pulling from it and you are returning its different path, but they are all in the same tube. Sorry?
Concentric ducting.
That's it. Do we understand that? So it's basically one tube branching out into two tubes, but it's one tube inside your body. Yes. Thank you for asking. The plasma that has been taken off, as you said, is placed in a biohazard bags. It's been in hospitals. We contract it to special people who come to dispose of it. They come and remove it, and all that is incinerated. It has to go to a special designated place where they will incinerate all of them.
Medical waste is burned for prison.
Yes, ma'am. Yes, ma'am. And it should never be placed in domestic.
Oh, I know, we have two, we have some people that put it in the wrong place, and we have to go dig it out with gloves.
So sorry, but it should be placed in biohazard.
Part of the job.
I know. And I mean, I always double bag them so that, it doesn't leak out or anything. It shouldn't leak. But, in disposing of it, one has to be very careful because it's body fluid. So you have to wear your protective PPE and all that.
Doing this plasmapheresis treatment, have you, well, obviously it's a dumb question. You've had to have your hepatitis shots. How often do you have those?
We do our yearly checks. All the nurses do yearly checks. We get our blood drawn at once a year, and our titers. When you do your vaccination, we check our titers once a year, and if it's not up to the level, you get a booster. Yeah. Yes, sir.
Kind of takes me on to my other question I was going to ask. What keeps you from, as a patient, from maybe the person before you did have hepatitis? I mean, how do you keep from communicating diseases in between patients on the machine?
Okay. Thank you. Good question. Okay. Now, remember I was telling you dialysis and plasmapheresis. Okay. Dialysis, the blood goes through, you have the fluid that we're using to dialyze the patient coming through the machine and flowing alongside the blood. So there's some kind of contact in the patient's blood. And so with the dialysis, you have to be very careful, and that is why after each treatment, the machine is bleached to kill every germs. This machine, if you look at it, as I showed you, okay, you see the blood is only in a tube. We use new tube per each treatment. And at the end of the treatment, it's all removed and thrown. What is left is the channel that we clean. We have a special solution we use to clean, which is disinfectant. It's very, I've never seen it to get a cross infection or cross contamination. I've never seen it. Because there is no water involved. You're not adding water or anything that is coming out or getting in contact with the patient's blood that's going through the machine. It's not happening that way. All that we're doing is we're removing it and we're giving it back to you. And so when we finish and we dispose of the whole thing, everything is removed from the machine. And then we just clean the machine. Once a week, we're supposed to use a special cleaning agent to go inside the machine, clean everywhere, and the tubes where the channel is, the black side, and the door traps, everywhere we have to do that once. And that is FDA recommended because we are being monitored by FDA. They come in every year to check us. They check our documentation. When we are cleaning, we're supposed to document what time we cleaned it. We're supposed to clean the machine before and after. So before we pull the machine, probably some of you have had it, wouldn't see it, but before the machine come out of the room, it's already been cleaned before we take it to you. When we're done, we take it back to the unit, we clean it as well. And everything has to be documented.
So you're saying it's cleaned twice before the next patient?
Mhm.
After the last
Pre
patient?
and post.
So
You mentioned one thing about the 5-day
Mhm.
the other day. Do you ever have the opportunity to see the lab results? In other words, where they look at counts and things?
Oh, we do.
And that's kind of my next question. Say, for example, I know it's not absolute, but say, for example, you remove 60%. And I know it builds back up theoretically one day to the next, but would you expect to remove 60%, and then on the third day, or the second time, 60% of that, 60% of that, 60%, you see what I'm saying, over the course
Yes,
of 5 days?
yes.
Do you see that in the counts?
Well, yes, because I have started somebody's count of about 5,000. And at the end of the 5 treatments, have got it down to under 500.
See, that's what I'm talking about.
So you can have a big drop in those antibodies. Yes, ma'am.
What is the source of the albumin?
The albumin is derived from human blood.
So it's blood donation.
It's blood product.
But different than plasma.
Yeah, a little different. Yeah. And that is why over on our side where I work, everybody receiving albumin or plasma have to have a blood consent because it's a blood product and you could react. And one thing that I forgot to tell you during the process, your blood is outside your body and it's in the machine. We have to find a way that the blood does not clot. And when your blood comes out of your body, you only have less than a minute and you see it goes, it clots. So we use a solution. And that solution works more like heparin, if you all heard about it. But the company recommends a solution called citric dextrose. And that's the solution we use, and we infuse that during the procedure. And that stays in the extracorporeal circuit, which is only in the tubing. Very little goes into your bloodstream. I'm talking about if we're using about 1,000 cc, you only have about 100 or 150 in your blood. The rest ends up in the plasma that we're pulling from you, and we throw that away. Even though you get only a small amount of that solution, there are side effects to that solution. It has a habit of eating up your blood calcium. That is a side effect of the citric dextrose. And so you will find that sometimes if you are to come to the unit to do this, we will give you Tums. We'll sit a cup of Tums on your table and say, here, that's your breakfast, eat. Tums is very high in calcium. And so when you eat it, it replaces any calcium you might be losing during the procedure. We also infuse calcium gluconate injection through the bag. So as our citric is running, our calcium gluconate is also running. So whatever you're losing, we are replacing. What are the side effects of that? Apart, the side effect of low calcium, because the citrate is going to cause your blood calcium to go down, to fall. And you will feel that you start tingling around your lips. You start tingling on your toes and your little fingers. And sometimes it feels like a bee buzzing. Zzz. That's how it feels. Or sometimes it feels numb. Now, we want to prevent a more serious reaction, which it can go on to become tetanus. Okay? So we tell our patients, let us know if you start feeling the tingling sensation, because we can help it. All we have to do is to just pause the machine, infuse more calcium, within a minute or two, it's gone. Okay? There's no other way. Unless you're allergic to citric, then we will be forced to use heparin. And the reason why we don't want to use heparin, if you compare heparin with citric, it's got a much longer half-life than the citric. Once we're done, the citric comes out of your system very fast, and you don't feel no more tingling. But the heparin, if you have issues with bleeding, that heparin is going to make it worse. And that is why the company recommends citric. Is that part clear? So you will find that when we're doing the procedure, we'll have those bags hanging. We'll have this dextrose, and we will have calcium gluconate. We also tend to premedicate you before the procedure starts, and there's a reason for that. You can react to the albumin that we are giving to you because it's blood product, so you can react to it. If we are giving you plasma, that's even more serious because you can't react to plasma. Because people who go to donate plasma, we have to give them citric, and some of the citric goes into that plasma. So if you think about it, we are giving you citric dextrose to prevent clotting. The plasma we are replacing your plasma with also contains citric. So you're going to be getting double dose. It's always important that we medicate you. And so what we give is Benadryl. We always give you Benadryl. It makes you sleep. He likes that. Yes, we recommend you get an IV, go straight into your bloodstream, just to try and mask any problem that may happen. Also gives you a bit of sleep and relax you. Then we give you Tylenol to prevent any reaction like fever and things like that before we start the treatment.
Can this treatment cause any type of meningitis type symptoms?
No, ma'am.
IVIG?
It's not known to do that.
How long is a typical treatment from beginning to end?
Okay. Setting up is the longest time. If we are using just albumin, which I have just finished one just before I came, and the whole procedure albumin took about 60 minutes. But it's just putting things together. We have to go to the patient room to do it or bring them to the unit. I prefer to go to the patient room to do it one-on-one. But the nurses on the floor, we don't work on the floor. But, sometimes we've been educating them because not everybody is used to plasmapheresis procedure. A lot of people don't even know much about it, even the healthcare professionals. So you call the nurse and you say, I'm coming to do this procedure. Can you get this, organize this, supplies for me? I need, 2 bags of citric dextrose. I need a bag of saline. I need calcium gluconate. I need you to organize all this for me. And quite often you go there and there's nothing, which happened to me this morning. So then you have to wait. So the actual procedure don't take that long, but the people you're working with, it's either the message don't go around and nobody knows anything, so you get there and there's nothing there, so you have to wait. So the procedure that shouldn't really take that long, this morning procedure took me from 12 o'clock till 4 o'clock. And the whole thing was like 2 hours. And I was using plasma, because plasma, you cannot run too fast because, people can react. So you have to be slow. Unlike albumin, you can run faster because it's not so much as the plasma. But even that, it shouldn't take me more than, from the setup to the treatment to the breakdown, shouldn't take me more than 3 hours. But you'll be surprised, 5 hours I'll still be there. That's because people are not getting things organized properly. And then there are delays. These things you can't anticipate. It just happens. But yes, if you're doing plasma exchange, that means you're using plasma as a solution, that usually takes a little longer. But the albumin solution for exchange usually take anything between an hour and a half. You're done. Yeah. Hour and quarter, yeah. I mean, one thing that we need to realize is that we don't set the time frame for the treatment. The machine decides. Because before you set the machine up, the machine requires you to put some data in the machine. It takes into account your weight, your height, your lab work, and then the machine calculates how much blood volume you got in your body before it decides how much plasma is going to pull and how long it will take to do it. And that's when the machine tells us, I'm going to do this in 2 hours. It's a pretty clever machine. Any questions?
How do people normally feel afterwards? I mean, do they feel tired? Do they feel depleted?
To that.
Okay.
I've only had it done about 20 times. And I feel no difference going in before or after. They always ask me, well, how do you feel? It's like I'm supposed to be floating, have a hangover or have a buzz. Nothing, I feel the same.
Because everything's
Never felt
balanced,
any
so that's
difference.
why.
Yes.
That's the key.
Yes. During the procedure.
About 20.
20.
But a couple 100,000 miles.
One thing we should know that during the procedure, we also monitor you very, very closely. I'll have you hook onto the blood pressure machine. If I'm doing plasma exchange, it's every 5 minutes, I'm taking your blood pressure. If it's albumin, maybe every 10 minutes. But I am watching, and we never leave your side until it's completed. With the dialysis, you can walk away for a minute or two, but not with this.
Is the patient asleep during this process?
They can go to sleep. They've had Benadryl, remember. So some of them will have a little snooze. But I don't mind. You can go to sleep. Let me do my work. And sometimes, if your blood pressure is dropping, I'll wake you up so that I can get a bit of pressure. But other than that, I let people go to sleep if that's what they feel they want to do. Yeah. But people they can read, they can watch television, they can eat while it's on the machine.
Lorna Doones. They give us Lorna Doones in the hospital. I'll sit there and you know my Lorna Doones.
Give me the Lorna Doones.
That's what we're bringing next week.
Okay.
Are those the cookies?
Yeah, a little shortbread,
Yeah.
butter, sugar, flour, nothing better.
Any more questions?
I have a question, and I'm gonna open it up to people in this room here who may have the experience And I transferred outpatient, and they started twice a week, okay? My query here has to do with the feedback between the lab that is doing this in the neurology team. And I'm not really comfortable with that communication and how it works. And the reason I'm saying this is that I went for 3 weeks in outpatient before I saw or established a relationship with a neurologist. And I'm very curious to know how she gets the information from the laboratory that's got this experiment called Hank going on.
Okay. This is how it works. Every doctor that takes care of you in a hospital has a privilege in that hospital. When I say that, it means they have access to the computer system. Some of them even have the computer lab system installed on their laptop, so they can view your results anywhere that they want, even at home. Doctors at Piedmont can sit at home and put orders in, and it comes straight to our unit. Okay, that's one area. Now, we work with the doctors very closely. We have their cell phones. In fact, I like to text them so much. So and they know me, so they know my number. So before I go to do a procedure, I will never start a procedure without knowing the current lab. So we do outpatient as well at Northside. When the patient come in, the first thing the nurses do is to draw the labs. And I don't start the treatment. I'll set my machine, but I do not start the treatment until I get the result. So if I get my result and there is abnormal result in it that I'm not comfortable with, I pick up my phone and I text the doctor. Hey, Dr. So-and-so, Mr. XYZ came for the treatment. Hemoglobin is very low. What do you want to do? And then he texts back. Okay?
So you're in communication.
We communicate so much with them. It's like somebody with a son. One of them, I call him my son, because I'm always talking to him. So, and it's very important that that communication goes. Most of what happens in the background, the patients don't know, but we do talk a lot. Because if you're having albumin exchange, what we need to monitor very closely is what we call fibrinogen, your fibrin level. It's very important. And each hospital has got a protocol to work with. Over on Northside, if your fibrinogen is below 90, we will not do it until they have given you a plasma. Because you can't bleed at the end of the treatment. And so I will communicate this with the doctor. And we already have the protocol anyway, so I don't even need to communicate. But as a courtesy, I'll let the doctor know fibrinogen was low. We are starting cryoprecipitate infusion. We usually takes about 20 minutes. And then drop another level before we start the treatment. And we have to do this. It's for your patient's safety. You don't want the patient to get into problems during the procedure. And so there are certain safety issues that we have to consider where labs results are concerned. And if, for instance, the hematocrit, the blood count is so low and is so dangerously low that bearing in mind after each procedure, you will drop your blood count a little bit. And so if it's not safe, I will not do it until it's fixed. And quite often the doctors will say, let's give a unit of blood, then recheck, then count again, and then do the procedure. So sometimes it may take a little longer, but we need to do things right for your own safety. Any questions?
So when you're getting this exchange, it doesn't matter what your blood type is when you're getting the plasma?
Okay. The plasma that we give usually, okay, if they want to give you blood, your blood type is very, very important. Okay. But for plasma, we say cross match is not required. Having said that, there's so much they can do. If you are O type, they can give you O. If you are O positive, if you're a positive type, they can give you O negative. And they can even give you AB. But there are other types that they cannot. They have a little bit restriction, but they can give you quite a lot. So they can get plasma for you faster than they can get blood transfusion. Because with the blood, the whole blood, they have to consider your type and cross-match. But for the plasma, you don't require cross-match. So they have a bit of leeway, in getting the plasma to you. So we get it quite a lot. Plus the volume of the plasma that we have to exchange, you'll be surprised. You're talking about, this morning I exchanged 10 bags of plasma in one go. So imagine if we have to type and screen, we'll probably be there till the next day. We can't even get anything. But because we don't require cross-matching, the blood bank are able to get it. And if they don't have enough, because all those plasma are frozen, and they get it from Red Cross. They don't have enough, they just order, and Red Cross deliver, and they just have to thaw it before. Oh, yeah. Takes about an hour to thaw them.
So it's warm when it's gone into the body? Or?
When they finish thawing, it's warm, but then they put it back in the refrigerator. So it's cold. And when we go to pick it up, we put it on ice. So it's very cold. And
Albumin as well?
the albumin, no. The albumin is usually, it's cold, but it's not as cold as plasma. But plasma is really cold. And that is why we use warmer. So as we are giving the procedure, we have a warmer attached to the machine that we warm your blood to your own body temperature before we give it back to you.
On the orders, how many of the times, just roughly between plasma and albumin, do you see half and half or outright?
Yes, we have done half and half in the past, and then it boils down to your blood, your lab work. I was talking to you about the fibrin, your fibrinogen level. If it has dropped too much, the doctors can order half and half. They can say, let's do half of albumin, half of plasma. And then we'll do it that way, and that should fix that level, the fibrinogen level. If you do all albumin, you will drop it even further. But if you do the plasma, you will replace what you've lost. Any more? Very quiet group.
What is the success rate?
It's very, very successful, so much so that most of the conditions is recommended as a first line of treatment. Most of the conditions I was showing you up here is the first line. When you get diagnosed, the first thing the doctor think about is this only plasmapheresis work. So they will even do that even before they think about any IVIG and all that. The first line is to do the plasmapheresis, get you to a stable condition, and then start other medicines. So yeah, in some conditions, very, very effective.
I'm going to throw a little caveat there. Is first line when you're in a crisis. Just because we were diagnosed doesn't automatically is the
Yeah.
first line of defense. It's when you're in a crisis.
Yes.
Because it is much more aggressive procedure than just taking methadone, for example.
Thank you. Yes, sir.
This is different than IVIG, correct?
It is.
Oh, what's
Well,
just if you could just simply explain what the difference is.
well, anybody here who has had IVIG?
All right.
Yes, I haven't heard from my lady at the back.
et cetera. The IVIG process is just an infusion. There's no exchange. There's no take output. It's only in.
Okay, I understand.
Yeah. Yes, ma'am.
So assume I've had plasmapheresis and you sent me home. The catheter is out. I only have some of my real plasma left. The rest is albumin. What do I need to be careful of? I mean, obviously, you're going to be careful of germs in general, but are there some aftercare things once we're done with the pheresis because we're lacking that much plasma?
Do you know you continue to make plasma?
But I know you're never done, but you don't have the same volume.
You should. Very soon you replenish everything.
So how quickly is the albumin out and the plasma back?
Not as quickly, but you continue to make it like from your bone marrow, you're making all these whole blood, plasma, platelets, you're making them. Okay, so it's not like a period, it's every day you're making these blood. Now, we don't know how long it takes for your whole body fluid, your plasma becomes your own, but we know that you have some plasma there, and that is why your antibodies continue to rise, because you're making those plasmas and you're making antibodies as well. Yeah.
So no particular things to avoid?
No. I mean, be careful. Sometimes your platelet may be low. So just be careful that you don't have an accident, like, bleed, anything that will cause you to bleed. If you have a normal platelet, that's fine. But what we tend to instruct patients to do after plasmapheresis is to eat diet that is high in calcium.
I am what?
Calcium.
Calcium.
So your yogurt, your cheese, the dairy products, they're very good. It helps body.
And now that's because it's citric, right?
Because of the citrate, yeah. And you may have dropped your body calcium. Even though we were replacing, it may not have come completely up to the level that you were in. So if you eat diet that is high, it helps replace. Plus, calcium also helps prevent bleeding and all other stuff as well. So they're very good. Then again, I would say, because we, at Northside, we also harvest stem cells. We use the same machine to extract stem cells. And if your loved one is diagnosed with cancer and needs a stem cell transplant, and she cannot use her own cells, but the doctors are recommending a family member to donate a cell, and if they test all the family members, and the only person that is a match, you have to be 50% or more match, has HIV, for instance. And they don't know before, they come in, we have to test them. All these tests, we test all that, and then it comes out. Then the doctors have to weigh, what is the benefit? Is the patient, if the patient doesn't get the transplant, he's gonna die. So do we give the HIV stem cell and treat the HIV? See, that decision has to be made, and the recipient has to be notified. So we leave that decision with the recipient. Do you want it? I want it, because the benefit outweighs the risk. So we go ahead.
Let's say the patient has HIV or the stem cell?
The donor.
The donor had that.
And we get that a lot, not only HIV, hepatitis, when we test it and, this is the situation. Do we do it?
But the person contract HIV that way?
Well, they can be treated. They can be given prophylactic treatment.
That's really scary.
Well, if you think about it, you're dying. It's the recipient that makes that decision. So, it's the same way, and I'm wondering if the donor is MG and the doctors weigh the benefits and the risk, and the recipient says, I want it because he's the only match. I think he has to go ahead and do it in that circumstances, yeah,
Those are extreme
extreme circumstances. Yeah.
outliers.
I mean, that decision has to be, it has to come from the recipient and the doctor.
Good information.
Just want to take an opportunity to say thank you to Doris very much for
You
being
are
here and for
welcome.
sharing all this great information. I hope all of you, I know I have, learned something different. We've had a plethora of IVIG specialists come and be our guest speakers. We've had, other different doctors but we've never had anybody, someone to talk to us about plasmapheresis. And even though we've had some members of our group that have had plasma, most of us have not. And either we've only seen it on paper, we've heard about it, but so I want to say once again, thank you for being here this afternoon
You're welcome.
with us and sharing the great information. I mean, a lot of it you may either assume or is general, but I think everybody here should be able to make the connection on how this is a potential solution or to help with our MG problems if we get into that situation. So again, thank you.
You are welcome.
All right.
It's a pleasure.